So of course, I think many of you know that basically for CTO, we always have the antegrade approaches and the retrograde approaches. This is just a broad summary of all the techniques that we can use. And today my focus will primarily be on the heavily calcified CTO because that's the one that can give us complications when we do these types of CTO. So firstly, we always believe that you need to analyze your angiogram carefully. For myself, I've always believed in using CT. So in 2010, I think we published the first paper in the world on CT-guided PCI, and this was actually, we did a small study in the year 2005, and then we published it subsequently, and it shows that if you use CT to help you in planning your complex procedures, you actually get a very good outcome and with very low risk of side complications, and also more importantly, you get good long-term outcomes. And therefore, nowadays you see that most post PCI patients, you hardly ever see anyone requiring bypass surgery. It's almost like zero. Yeah. But later on in my second talk, later on this afternoon, I'll share with you about some of the advances in imaging. And one of the biggest advances, which I think will be very important in cardiology and also for PCI, is actually the photon counting CT. Because which I will talk about later on. But as you can see in the images here, on your left side, that is what the conventional CT would look like. But if you use a photon counting CT, you can see the calcification very, very clearly. But I'll talk more about this later on in the talk. Yeah, so I won't go through the details, but generally, if we expect it to be quite a difficult CTO, you probably want a dual injection angiographic assessment, all right? And then, of course, you look for a few things, whether there's proximal cap ambiguity. You also want the CTO length, which usually we measure from the CT angiogram rather than from the angiogram itself. And then, of course, your distal landing zone, and you'll be looking for any collaterals in case you need to do a retrograde. Yeah. So if we look at heavily calcified CTOs, and if you think that you are able to do an antegrade approach, so firstly, we will look at using the antegrade approach first to try to do a CTO. And if you expect difficulties, you will want better support. So you might want to you might have an anchoring balloon, you might have a better guider like an M+ guider, and you might need some special microcatheters as well. So firstly, we will try, as always, if we think that we can do it antegradely, to use wire escalation. And generally, you would want to say that if the lesions are not long, no proximal cap ambiguity, and good distal targets, you generally want to do that. Typically, I would start with Fielder XTA, and then of course, different people have different choices. They may go up to medium loads wires, and then finally use high load wires. But of course, everybody has a different technique. And these are, of course, some of the usually I typically start with fine cross, but of course others may have their own choices as well. And then of course wires, there are different wires. So lower, as I said, normally I start Fielder XT, but then we will push up to either UBS or I used to use Gaia, but now the initial Gaias were not so good because they get trapped sometimes and it's very difficult to dislodge it. But the new Gaia NICS wires are supposed to avoid such problems as well. Now, let's say if you try antegrade approach and you can't quite, you have some difficulties getting the wire through, then of course you want to try the parallel wire technique based on this algorithm. And of course, once you enter the subintimal space, you want to leave it in position to seal the track. And then you will want to advance the wire close to the distal cap, all right? And don't collapse the distal true lumen. And then you will need another penetrating wire using a microcatheter, and you attempt to enter the lumen through that. So this is the parallel wire technique. And sometimes if you use a microcatheter like a Crusade catheter, it might be helpful because it's a double lumen catheter. So this is one thing you can use. So if you find that you have impenetrable proximal cap, that means you have to use other techniques. So obviously you cannot go through the actual cap. You have to do extra plug techniques. And that means that you have to actually do an interior dissection first to get access. All right, so in anterior dissection, antegrade dissection, again, you don't want lesions that are excessively long, and you want to make sure you've got good distal targets. Otherwise, it might not be the best choice. And obviously, if you use that, you can either use wire-based or device-based techniques. All right, so for the wires, you can use various techniques. I won't go through the detail. You call it scratch and go, where you put a high tip load wire, and then subsequently you put a microcatheter, and then you knuckle the wire through. That's one way. Base, I'll describe in the next slide. And Kalino, I won't go through it because Professor Kalino is here himself. Yeah. So base technique is basically a balloon-assisted subintimal entry. Use a semi-compliant balloon, polymer jacketed wire, and then after you try to bypass the heavily calcified occlusive plug. And at the base, side-base technique is just a variant of that, yeah. Okay, then for subintimal knuckling, so now we've decided to go to technique number 2, which is, this antegrade dissection. Then, of course, you want to use the right wires as well. You can use something that's simple like Fielder XT, or there are some specially designed wires. But if for whatever reason you need a big knuckle, then you might have to use higher load wires. Well, some people prefer the cross bars, but of course different people have their choices where you need to rotate this very fast to try to get it across. Now, after that, if you find that your wire-based techniques don't quite work out, then of course you want to go to device-based techniques. So device-based techniques, you have the Stingray balloon, which I'm sure many of you are familiar with. You need to align the markers so that the markers are aligned. Then once the markers are aligned, then you use a stiff wire to try to penetrate the distal part and get into the distal true lumen. Okay, then obviously, these are some of the important points to note too, that you want to make sure that you don't get a huge subintimal hematoma. Otherwise, it might close off the distal cap, make it difficult to do it. And then landing zone, you need to control the wire tip. And of course, always remember that once you're through, you want to avoid distal perforation. Don't forget to change your wires. Yeah, so this is just the recross device, which is similar, but instead of using the Stingray device, you have a catheter that actually allows you to do a similar job as well. Yeah. Okay, so just now I said the wire-based techniques. Yeah, there are many techniques with different names. So you have like star, mini star, AFR, last, and last technique is you've got to be quite careful because you're using a very stiff wire, and then of course high risk of perforation, and it's probably something you'll leave to the last. Yeah, literally, yeah. So these are just illustrations of the different techniques. Again, I won't go through in detail, but you have various choices. And then AFR is also a similar technique where basically you put 2 wires through, inflate the balloon, and use the second wire to advance through the true lumen. Sometimes if it's appropriate, you might want to do IVUS as a PCI sometimes. And again, the IVUS can help you, especially if they say you want to image and you have a proximal cap ambiguity. And sometimes it can help you in terms of the antegrade re-entry as well. But this technique is not so straightforward. So obviously you need people who are very well-versed with it, who have done a lot of it, and for this to be done successfully. Yeah, so I won't go through this in detail, but yeah, this is one of the techniques you can use. Now, if all else fails, and let's say, for example, you have tried various techniques and it doesn't work, then obviously we have to fall back to the retrograde approach. Okay, so retrograde approach, again, same thing. There are various ways of doing it. Retrograde wire escalation. Now, usually for me, I would look at the CT very carefully first and analyze what the calcium is like first before deciding on which approach. But most of the time, it will be a reverse cut. Yeah. So this is a reverse card. I don't need to go through the details. I'm sure all of you experts are all very familiar with the technique as well. Yeah. Yeah. And then I think the important thing, whatever technique you use, I think one has to be cognizant of the complications, because one of the things that you really want to avoid is complications. So obviously you don't want to, especially if you are crossing the collateral, you really don't want to puncture a collateral and cause either big hematoma through the myocardium, or you get a worse still, a pericardial effusion, and of course you need to do pericardial centesis as well. And you also want to be careful about the donor. So when you're using your guide wire, your guiding catheter, you have to be quite careful that you are not so engrossed in doing the CTO that you don't position it well, and you get complications with the guide wire as well, guiding catheter as well. And of course, losing side branches as well. Important thing is, not to lose your side branches, and excess side, complications as well. Yeah. Okay, so sometimes you've tried everything this way, that way, but you manage to get a wire across, but hey, you cannot get your balloon across no matter what, and you've got quite a bit of difficulty in trying to put even a very low profile balloon across the lesion. So this is where your wire can cross, but even the microcatheter may not be able to cross. So if the microcatheter cannot be crossed, because you may have what we call a concentric calcification, which is with a very small lumen. And so, of course, we have to look at techniques to deal with heavy calcium, so the atherectomy techniques. Same thing, sometimes you need a good support as well, so do the necessary in terms of whether you need an anchoring balloon, guide extension, or the M-Plus catheter support as well. Okay, so atherectomy devices, two of them primarily. One is the orbital atherectomy system, which is bidirectional, and you don't need a nitrogen tank for that one. And the burst comes in various sizes as well. And then I think the one that has been around for a longer time, which most people have been using, is rotablator by Boston Scientific. And again, they come in different sizes bursts, but generally, we would generally want to start off with a smaller burst size first. And if you are treating the RCA, you might want to provide or be in a position to put a 10 pacer if you should do so, if you need to do so, all right? Or leave a 10 pacer there before you do the right vessel. So these are some of the details, and of course the technique is very important, because if you're not careful, especially in a very, very heavily calcified lesion, your burr can get trapped inside. So you have to be, if your technique, you have to be quite careful in your technique, so that you don't end up with your burr being caught inside the calcium. And of course, if a very heavy calcium load, you must be also cognizant of this problem of slow flow or no reflow phenomenon. So I think that's something that we need to be especially careful if we are going to use this in a very heavily calcified region. Okay, this is a very busy slide, difficult for everybody to see. I'm sorry, but just to show you a comparison between rotational atherectomy and orbital atherectomy. But I just highlighted there that if you are dealing with a concentric lesion, very tight, I still think that, at least for myself, I think, rotational atherectomy is something I would prefer to start off with, and, size up the burrs and do it this way. The rest are really some technical differences in the two different systems. Okay, so after you've gotten, you managed to get a bigger lumen, then you might be able to put in what we call a shockwave IVL. Usually the shockwave, as most of you know, is quite bulky. So sometimes if the lumen is not very big, you might have a little bit of trouble trying to push the shockwave, but it actually works very well. Yeah, it actually works very well, yeah. Okay, then of course, some people will still try, no matter how, instead of using a rotablator, they will try to use this technique called balloon-assisted microdissection. So basically, they use small profile balloons and try to inflate rupture to create microdissections and try to push it through. Now, finally, you come to the scenario where, okay, you've managed to do all that is necessary. You can put your balloon through, but then when you try to dilate your balloon, you cannot get a full inflation. So then, obviously, we cannot deploy a stent in such a situation. We need to optimize the vessel before we attempt to do so. So again, there are same thing, you can use and size up the burr with an atherectomy device, or you can use a high pressure balloon, cutting scoring balloon, or again, you can use IVL as well. So, so you can now, there are these very high pressure balloons, you can go up to 40 atmospheres and, you can crack the lesions. Most of the time it does so. This is just to give you a sense of the pros and cons of the different techniques. But by and large, for calcified lesions, you can use either cutting balloon, a scoring balloon where the wires sort of round in a helical manner, or use a very high pressure non-compliant balloon. Plus and minus, of all, So these are the various differences with the different various techniques. Then finally, obviously, now we assume that we have successfully opened up this calcified lesion, and last but not least, stent implantation. That's the easiest part. So I think thank you for this opportunity to let me just go through, how we would do it for calcified lesion. And thank you all at the end of my talk. Thank you very much.